Hi, I'm Dr. Joe Suker with the Arizona Trauma Association, and this is Trauma in a Flash. Posterior hip dislocations account for 90% of all hip dislocations. They typically occur with an axial load on the femur when the hip is in flexion and adducted. Many are associated with posterior acetabular fractures. Femoral head fractures, such as seen in this video, can also be present. Sciatic nerve injuries can be seen in as many as 20% of dislocations, and up to 25% can be associated with ipsilateral knee injuries. Therefore, always perform a focused neurologic assessment and diagnostic imaging that includes the distal femur. Reduction of hip dislocations should be performed within 6 hours of injury to reduce the risk of femoral head avascular necrosis. There are numerous methods for performing a reduction of the posterior hip dislocation. In 2016, Waddell and colleagues described the myriad of reduction maneuvers in orthopedic reviews. This includes the following maneuvers: the Alice, the Bigelow, the Lefkowitz, the Captain Morgan, the East Baltimore lift, the Howard, the lateral traction, the piggyback, the Tulsa Rochester Whistler, the scoff, the Stimson, the traction counter, the flexion adduction, the foot fulcrum, and the author's own, the Waddell maneuver. There's even a maneuver called the rocket launcher. I'll cover these techniques in this short video, but not a chance. In this episode, we'll show a modified Captain Morgan technique. As with all procedures, the key to success is good preparation and great help from your staff. Additionally, moderate IV sedation is essential for hip reduction, given the significant associated pain and the fact that the hip is supported by a group of large muscles. Here we see a plain film showing the right hip dislocated from the acetabulum. The CT reveals an associated femoral head fracture. The patient is positioned supine. Once the patient is adequately sedated, have your assistant stabilize the patient's pelvis. You may need a step stool to gain adequate height. Place your foot on the bed and the patient's leg over your knee with your hand underneath the patient's knee. This is a positioning for the Captain Morgan technique. In the traditional Captain Morgan technique, you lift your heel, pulling the patient's leg anterior while your assistants apply countertraction on the pelvis to ensure it remains firmly on the stretcher. Here the physician modifies the technique, placing his left hand under the knee and his right hand over the thigh. He applies anterior and inferior traction to the femur, essentially using a combined Lefkowitz and Captain Morgan technique to achieve rapid reduction. The post-reduction plain film shows very good reduction with near perfect anatomic alignment of the femoral head fracture. In this case, 5 pounds of Buck's traction is applied due to the associated femoral head fracture. This is not necessary in cases of simple hip dislocations. Thank you for watching this week's episode of Trauma in a Flash.